Okay, I'm going to call the Winnebago County Community Mental Health Board to order. And today being November 2nd, 2022. Roll call at this point in time, Mary Ann Abadi present, Dr. Copeland, Dr. Jerry Giardini,
Here.
Dr. Bill Gorski,
Here.
Richard Cooner.
Dick.
Dick
Here.
Cooner,
Here.
pardon me, I'm reading it right off the note here today. Wendy Larson Dennett, present. Tim Neighbors. Linda Sankflex will not be with us. Jason Holcomb,
Yeah.
director, and also Nicole Bennett is on staff and he's big help to the mental health board. So thank you all. And I want to welcome all our guests today. And I know that you're going to be giving the presentation. At this time, we have not had any requests for public comment. So next on the agenda will be the presentation, and I would ask you to all just introduce yourself as you speak.
My name is Chris Nichols. I'm the team lead for the crisis code response team here in Winnebago County. I've got Chrissy, one of our clinicians. We've got Officer Palmer with Loves Park Police. We have Bree, our nurse. In the back behind Bree, that's Detective Kohani with Rockford Police. We have Jason, who is the director of crisis services. We've got Deputy Eisman and Deputy Turner with Winnebago County Sheriff.
Welcome.
Welcome. Yeah, thank you. Welcome and thanks for coming.
Yes.
So the crisis correspondence team currently has 5 clinicians on board. We are actively hiring for that 6th position and actively interviewing. We also have Bree, who's our part-time nurse, on with us. We have 4 city police officers. Currently 3 of them are out on live calls and follow-ups. We've got Officer Wells, Officer Walker, and Officer Macias. We also have Dee and Rebecca and Allison, who are clinicians. They're also not with us today. So the crisis corresponder team, do you want to go to the mission statement, which is the 3rd slide? The crisis co-response team is a partnership between law enforcement and mental health professionals that uses a co-responder model to improve community wellness through a collaborative response. We work to promote safe encounters between individuals in crisis and law enforcement. And our intention is to engage, stabilize, link, and follow up with those individuals that are experiencing a mental health crisis in order to strengthen the community. Next slide. The co-responder programs like ours have been developed and implemented throughout the country. There are similar programs seen in states in Arizona, Georgia, California, Connecticut, and also Illinois. The University of Memphis Crisis Intervention Team reported in 2019 that there were over 2,700 crisis intervention teams within the U.S. Our team is working on a pilot as of fall 2020. And in 2021, they were able to expand that. And so now we have on a full staff minus that 1 clinician. So we were a pilot program in 2020, and then in 2021, we got the approval to move forward and expand our team. Next slide, please. Our goal for the community is to divert the most vulnerable population with severe, persistent, and chronic mental illness. Individuals who may have co-occurring substance use out of the criminal justice system and connecting them with treatment and other support services within the community. Basically, what we do is we want to avoid any jail time or if possible, them going to jail. And if possible, we also want to refer them more to triage services versus a hospitalization if we can. Upon referral, CCRT will follow up with not only the client, but also their support members, family, friends, anybody who is a support to them. We provide that education to. During a live call, we can assist in de-escalating, assessing, and linking them to services. CCRT offers a behavioral response to behavioral health crisis with the goal of avoiding hospitalization or incarceration. With individuals in crisis by providing rapid evaluation, intervention, and referral to the appropriate level of care. Next slide, please. What a mental health crisis looks like, it's a situation in which a person's actions, feelings, and behavior may lead them to harm themselves, others, or increase the risk that the individual may not be able to care for themselves in a healthy manner. Certain instances, they're having suicidal or homicidal thoughts, or they could unintentionally harm themselves or someone else through unpredictable or uncontrollable behavior. Next slide. So CCRT is open to everybody within the county. It's a national program. Individuals who need it are able to utilize that as long as the county that they're in has those services. We've been to the most affluent areas in the county, and we've also been to some of the poorest areas of the county too. There's really not a specific number on where individuals are in terms of demographics. I think it's pretty well balanced out. Next slide. So our approach is to receive referrals for calls of service, mental health transports, 911 calls. We also work with the Winnebago County Courts and other agencies in the community at large, and that's where a majority of our resources and referrals come from. Provide case management for members of the community in an attempt to reduce those 911 calls, avoid future crisis situations, and develop recovery and stability. And to provide public education with hopes of reducing the stigma associated with mental health illness. Next slide. So the unmet need for mental health services, the lack of social services across the U.S. has resulted in law enforcement officers acting as first responders to mental health, homelessness, and substance use crisis. Our local effort is not to replace law enforcement, but to work side by side with them. And it's an equal partnership. Nationally, according to the CDC, suicide is the 12th leading cause of death in the US. The CDC also reported that overdose deaths increased by 28.5% between April of 2020 and April of 2021. NAMI reported that 1 in 5 adults experience mental health illness each year, and 1 in 6 adolescents experience a mental illness each year. And then locally, between June of 2021 and June of this year, we responded to 2,454 calls, with 1,721 of them being unduplicated, meaning they were single service calls. So only about 700 people we met with were those duplicate calls. Next slide. So this is just a breakdown of the current populations from January 1st of this year until October 24th. For substance abuse, unduplicated calls, we had 186. Total is 214. Mental health, 632 unduplicated, 1,611 total, and then dual diagnosis, 138 unduplicated, and 156 total. Next slide. We do work side by side with MIH, the Mobile Integrated Health Team, through Rockford Fire. We will respond to calls if they request us, and they've also come out. Clinician Wilson also has used MIH a few times. MIH, one example, MIH was contacted by CCRT to go to the Rockford Rescue Mission for a woman that was schizophrenic. She was refusing to leave and refusing to speak with anybody that was with law enforcement. MIH was able to come in and eventually speak to her, and she was willing to leave finally from the mission and go to the hospital with that person. So it's been a great deal of success, and also they called us. We've worked with individuals that may be linked with MIH. We may end up going back out there to assist them with what their needs. So we try to collaborate with them as much as we can. Next slide. So recent success stories. This is just a couple of them. On August 1st, deputies were dispatched for a suicidal subject with a plan to take pills. When deputies arrived, the client's wife stated that her and her husband had been arguing and going through the beginning stages of a divorce. The client stated that he was going to take all his pills so he wouldn't wake up when their adult child was able to remove those medications from his home. Client stated to deputies that he's had suicidal thoughts in the past and said that he would take the pills to never wake up again, but denies any suicidal thoughts, stating that he wanted to take the pills to commit self-harm during that event. He agreed to transfer to Swedish American. It was transferred without incident. One of our clinicians that isn't here today, she followed up with him for his 90-day follow-up. He said that he was doing well. He's enjoying his OP services and is still currently engaged with them. He also stated, before CCRT, I was in a really bad spot. CCRT saved my life. Next slide. Another example, in February, officers were dispatched to the listed address where the client was reported as having a mental breakdown. He left the area prior to officers arriving on the scene, but later returned. He advised he was schizophrenic and medically compliant. He said that he was not suicidal, but did request that ride to Swedish American, where he was transported. A few months later, at 6:30 in the morning, the client was in an altercation with his brother. While speaking with police, the client said that he has schizophrenia and that he is suicidal every day with a plan. And unfortunately, he was ultimately arrested for domestic battery. It took us some time to finally track him down after he was released from the jail. But what we did, he reported that he was in services and therapy. On October 28th, we contacted him again for his 90-day follow-up. He reported that he's continuing with that counseling service, complying with his meds. He said that he recently had a family member pass away. We offered brief services, but he says that's something that he's been processing with his counselor at the time. This is just some of our contact information. This is my contact information as well as our office number and a few resource numbers. The next slide is what our CCRT flyer looks like, and I actually have those. I can pass them out. Yeah. Oh, there should be just enough. Usually when we leave our door hangers, they're usually stapled on here. So the only time that we don't staple, obviously, is we let someone in the jail. But this is how they look when we leave them on the doors, or if we're able to meet with that person and hand them off.
We also have them printed in Spanish.
Yes.
So we fold it up and then staple it to the door hanger.
Yeah, here.
Oh, yes. And we all, each deputy and officer also will staple their contact card on here. And then the clinicians also have cards, so if we're with the deputy or officer, we can leave our cards with them as well, so they can reach out to us. Really the end of the presentation. Does anybody have any questions that myself or the team could answer this?
Did I hear you correctly say that you have live calls as well? That seems like most of your contact comes through referrals, but you mentioned a live call. Could you describe the scenario or an example in which a live call was in real time you're responding? How does that work?
So when a call is called in to 911 dispatch, the responding officer can request for us to come out, or if the dispatchers are aware of the services we provide, they can also give us a call and say, hey, we think this might be a call that you need to respond to with a patrol officer. We're also monitoring the radio in real time. So if we do have calls that come in, or if we hear the name of a person that's on our caseload or we've dealt with in the past, we'll usually follow up too. So a live call is anything that's happening in the moment. So if they're having a mental health crisis, we can get out there, assess them. If they need to go for triage at the Mulberry Center, we can do that. We can take them to Swedish American or another hospital for a 4-5 to be assessed and maybe even sent out to Chicago or somewhere else for hospitalization. So when we say live call, it's we're just not doing that follow-up. It's we're actually responding to that call with a patrol officer.
Great, thank you. That's the minority though.
It's getting to be more and more now that we're being established. The patrol officers are really familiar with us being on this unit. So it's becoming more often that the officers will just ask for, they go by call signs. So they'll ask like is the NORA unit on the radio and request us for assistance. Because they're pretty good at noticing when there's a mental health component, the patrol police officers, to what is going on. So then they'd rather we come and kind of just link them to services and that, so they don't just have to go to suites, because the only option patrol has is the Form 5 to suites. So they're hoping that if we come, maybe we can convince them to go to the Mulberry Center. for inpatient for 2 weeks and that happens, we're able to get that done, so we don't have to go to the hospital.
I'll let her add to that. So another component to the city, what the reason they would call us out is if it is like a suicidal subject, where it looks like, okay, they might have to go hands-on with this person, just to have an extra perspective from the clinician to talk to them, to maybe de-escalate the situation to where less use of force would have to be used in that situation, being a mental health.
Great.
So it was interesting to me that you're linking somewhat with the fire department and their programming. But the one example you gave about somebody who'd been involved with CCRT and then was jailed. I thought somewhere along the line, there was supposed to be a warm handoff so that we aren't losing track of these people who are part of, that CCRT already knows about, they're in jail, but then we're connecting them immediately to services. So is that still a work in progress or?
We try, it's, sometimes it can't be immediate, just because maybe at first they're unwilling to help or unwilling to work with us. There's been there's a couple of people that's arrested later and then they're finally, hey, something's gotta change at this point. I'm willing to step up and accept the help that you guys are offering. So, and the warm handoff per se is sometimes we don't even know they're being released. Like,
So, okay.
like some of the judges will write on their release to us. And then if sometimes it says release to us or comply with CCRT, but if we
There's no.
weren't in court when that release was issued,
It
or
doesn't happen.
we don't know anything about the court order, then there's not a lot we can.
But I'm currently working with some clients right now and that I'm literally going to court for tomorrow. They're in custody now. I have linked them to an appointment. And I make the appointment far enough away to hopefully that I don't have to cancel it because let's say they're not released.
Right.
The judge does look at when CCRT is in the courtroom.
Yeah.
Very fondly and goes off of our recommendation. So if we go in there and and of course, we get permission from the clients to talk to the courts on their behalf. And then we'll ask us, like, what do we have going on? So this one client that's currently in jail had an appointment for linking to outpatient counseling on the 7th. His court date isn't until the 8th. Well, that's a problem, right?
Yes.
So I made sure that I called Rosecrans and had them reschedule it. So now they were able to reschedule that appointment till the 21st. So then when he gets out, he can go right to that appointment. I've also made sure that I called because the judge always wants to make sure they have a place to go. So we confirm that he can go stay with his grandma once he gets out. So he's not going to be homeless. And grandma and grandpa are going to pick him up. And so we got clients that we do work real close with through the jails, and through the courts. And then on his next court date, I'll go again. And then the judge is going to ask where he's at. And hopefully, like we've seen in the past, that they remain in treatment and they're doing well and they're continuing to receive care.
So is there something, I'm just thinking from the state's attorney's perspective, is there some training or information that needs to go to the particularly inexperienced state's attorneys who are popping up in your bond court and don't know which end is up so that they recognize?
They often ask us straight out.
Okay.
And I get them in the jail too that collaborates with us, we do the same. And then, Judge Gibbons is really good. I know they're also in the process of getting a court liaison hired, for Judge Gibbons' court. And that'll, also kind of help get us more, collaboration too, if we're not able to go to court, to meet with specific
Yeah,
clients.
always be in that court.
When did we get the arraignment court docket every day as well? So if there's somebody on there that we have been trying to work with or that we recognize, I've gotten pretty good at emailing or just calling a felony review because that's who's doing bond court anyways, and letting them know that we are trying to work with them, and that way they have some type of awareness that we're trying to get involved.
Just any ideas you have, I think Jay would be receptive to.
Staying in contact,
Yeah.
which I've said time and time again. As long as we have that line of communication to where if someone's being released, they want them to follow up with us, that we know that they need to follow up with us. So,
When someone's Form 5, are you guys involved at all in terms of when they get released or?
We have a good relationship with Swedish American. So, because when someone's in crisis, that also, helps because HIPAA doesn't quite apply when someone's in crisis. So we're able to share information, which sometimes we wouldn't otherwise be able to. So every day we actually call Swedes on clients that were Form 5,
Right,
sorry,
that's okay.
that were Form 5 for patrol the night before. So if we came in this morning, we would look at all the police reports and we see that clients went to Sweden, they were transported to Sweden on a Form 5. So I'll call and talk to assessment referral and like Katie or Samantha and ask them if those clients were released or admitted. If they were admitted, it's kind of like a waste for us to go knock on the door to feel they're gonna be in Sweden for that day, right? So then they'll let us know if they were admitted or they were discharged. If they were discharged, we can do our follow-up. If they were admitted, I call again. When I call again the next day, I still see if they're still admitted or were they discharged. So we keep a pretty tight handle on when clients are discharged from Swedes. Swedes has also reached out to us at some point and have clients that, let's say, were 5, they didn't have enough to hospitalize them, but they also didn't feel comfortable discharging them to the street. So they'll call our unit and ask us if we can go ahead and help them get escorted to the Mulberry location. So then we'll help get that established at Mulberry and have them, they want to step them down, they just don't want to discharge them to the street, especially if they're homeless too, because then we have a hard time finding them after that point. So we are all kind of really working together.
So a patrol officer can't just drop someone off at Mulberry?
They can,
Yeah, they can.
yes,
Oh, I thought I heard something different.
No.
They can do so.
yeah, they absolutely can do it.
Good, okay.
I think more, I think since our unit was developed, they know they can now. I think maybe at one point they didn't realize it so much, but it's more of a current thing now.
That requires the person to agree.
Correct, because that's voluntary. That's the difference between the 5 and going to Mulberry is that it obviously is voluntary. So sometimes, and I will say, sometimes clients will say, yeah, officer, please take me to Mulberry. And the officer takes them to Mulberry, escorts them in and says, here's the client. They sit in the chair, the officer drives away and the client walks out. So,
there's a lot of times that people don't want to go to the hospital. And like, I'll go somewhere, but I don't want to go to the hospital, and Mulberry is the second best place to take them at that point. Because they're still trying to go somewhere, I guess would be the best place, but they're trying to go somewhere, but they don't want to go to the hospital, so Mulberry is the option at that point.
Once I had a client that he had been to 2 of the 3 hospitals on Form 5s and was released, and when he was released, he still was not where he needed to be. I had left my door hanger on his door, and he ended up calling me, and the clinician and I went out, we picked him up, we brought him to the Mulberry Center. He had some medical issues, and we kind of helped coordinate some of those medical issues with the Mulberry Center so that he was able to stay. And he stayed for, I mean, a good 2 weeks. Yeah, and last I heard, he was doing well. We helped facilitate, get family. He was evicted from his home, so we helped facilitate him getting a bus ticket to go live with his sister, and she's in Texas. Last one of the clinicians did a follow-up. He was sober and he was stabilized with his mental health and doing much better.
Wow.
So we do follow-ups with each person, 30 days, 60 days, and 90 days from that last call of service. If they have another call for service at any point, the clock really restarts back at 1. So it'll always restart when they have the most recent call for service. But we at least try to contact them for 3 months. Sometimes it's either something done, if they're homeless or they don't have a phone or their phones are turned off. It takes a little bit more hunting, and sometimes we're successful and sometimes we're not able to locate them. But I think we've been pretty successful in being able to at least locate most of the clientele. I know that we have a 75% response rate within 48 hours to meet with them for a follow-up if we're not responding to a live call.
I have a question about a call. If the dispatch were to get a suicidal call directly, either from the family or the patient client, do you ever send a clinician with the police when they respond?
Only if they're requesting one of the NORA units or one of the other officers. Usually patrol will still respond out there first and they can assess. But if they're struggling with maybe trying to speak with that person, they'll call for us and we can go out there. Sometimes what I've seen too in the reports that we get is the patrol officers are really good at being able to at least de-escalate and get them in.
That's what I wanted to know next. is,
Yeah.
Do they have the training for de-escalation, everyone that responds to these suicide?
A lot of our officers, I think with all of our agencies are CIT trained, so,
Okay,
and now with the new Safety Act, we're gonna be implementing a lot more training on mental health. Shelley and I, we both, all of our new recruits go through a county school. So once they're finished with the police academy, then they have a 2-week county school. And we give a presentation to them about our unit and mental health in general. To try to give them a little more education before they hit the streets. And then most of the officers and deputies are really good about giving us a call. If we're not dispatched out there, or we don't hear the call come out because we're out doing follow-ups and out in the community, if the guys are struggling on the street, they don't hesitate to give us a call. And a lot of times we can help them over the phone if we're not able to go meet them in the community. Otherwise, if we're not busy on something, we'll just go and help people out.
We also want patrol, our team wants patrol to be there because these officers want to be known as the kinder, gentler police. We don't ever want someone from CCRT to have, the police officers to have to tackle somebody, put someone in handcuffs and arrest them. So with patrol being the bad guy kind of thing too, is so that's why we almost always, I should say, respond with patrol, because we're kind of like trying to get the community to understand there's a different side of policing. And a softer side of policing. And so if we know that this person might get escalated, or there's, it shows in the report that there's aggression history, then we for sure want patrol with us when we go out there, because then, you know, they'll look at patrol different than the crisis co-response officers.
The other thing too is we have Bree with us that can go out with them and she can medically assess. So maybe if they're not quite sure if it's more mental health related or medical related, we've got the opportunity to have Bree go out there and assess them medically to see if maybe they need more of a medical hospitalization. Because sometimes it's something as simple as a UTI that could be causing some of those mental health symptoms. And we've actually seen that pretty frequently too come through, where someone is acting way out of the norm, and everybody thinks it's a mental health episode, but really it turned out to be a UTI. So it's nice to have Bree here because we get that medical perspective on things that maybe we can't look at and see.
okay, thank you so much.
I want to recognize 3 people over here who I have a great deal of respect for. Nate Kohani right here, guys, was our police liaison at East High School. You talk about a really good, effective, and respected man who was right here, Nate Kohani. Kids, I mean, he handled things well. Teachers, we all liked him. I'm not gonna say love, that just goes too deep. But he was well liked, and he's right for this position. He is right for this position. So Nate, thank you. Deputy Eisman's over there. She and I went through the same training 3 years ago, and I'll spend that hostage negotiation. Deputy Eisman has been spoken very highly by her peers. Being that I'm with those guys a lot from time to time, and when they speak of her, they speak highly. And the same with Deputy Turner in the corner. I've had the privilege of riding along with her. One of the few women I've ever ridden along with. I tell you what, she's wonderful. She's one of those people where you pull somebody over and then I walk up to the car and make sure they're okay. And then they'll say, this lady one time said, that is the nicest police officer ever. And I thought, you know what? That speaks volumes. So those 3 who are doing this are the right people. And I'm glad we're funding this. And I hope we continue to, because they're good people. Yeah. Well, I mean, but guys, and Detective Palmer, I hope we cross paths someday. I really do, in a good way. You know? And I just gotta tell you that those three alone, I wanted to say that because I think they're wonderful people. They're quality individuals that are doing this job, and I've had the privilege of working in one capacity or another with them, and they are perfect. Now, how's that?
Thank you.
You bet.
Do you have anything positive to say about Terry?
Now we're gonna have to, right?
That's gonna get deep.
I have one quick question, Marion, and kudos to all of you. Terry, thanks for saying that. This may be more for Jason, but maybe I'm the only one who needs to be reminded, but of the mental health board funding to this program. Can you describe or remind me what magnitude of the program or its components are supported by our funding? Because frankly, I don't remember.
Well, it's my understanding that we're funding 100% of the program. There is no revenue generation from this program. There's no additional funding for this program. So everything we receive shows that we are funding this in full.
I wanted to get that out there, though, to be sure my memory.
And drive the point home to all.
Yes. Well.
Well, and I guess my question is, what are, as people who are sort of boots on the ground, what do you see as the next iteration of what you're doing? I mean, I've seen, there's a sea change that has gone on since 2020 in how our community views the interaction between addiction, mental health, and criminal justice. And you are the natural response to that growing awareness. What do you see the next steps as? Just off, not in
that for a second.
not in stone, but.
I just say this because I was one of the members in the pilot program, and I know initially when we started, we didn't have the staff, we were only 5, and that was between the clinicians and officers, 5 total. So I know we had discussed, and Deputy Eisman was in the pilot program with myself, and we had talked about, because it was strictly at that point, it was a follow-up unit, because we just didn't have the manpower. So it was all 24 hours, 48 hours on the, over the weekend. So it was talked about that there would be more live calls, as you guys were suggesting at one point. Having that manpower is just where that lies in being able to do that. If we had enough people that could still follow up with those 30, 60, 90s, because we're still doing that and going to live calls and then following up on new ones, then I think the goal when we started, and if I'm not mistaken, if that's correct, to me, was to be more like available to go on when we hear our suicide subject come across the radio from dispatch, that we would automatically respond and not wait to be called.
Right.
Does that make sense?
Yeah.
And that's what, the main thing was that we were trying to work on, at least getting, to that point.
So what would your feeling be? So like, if you're a violent crimes detective and a dead body is discovered, on State and Wyman, it's patrol that responds, but you're getting out of bed at 2 a.m. to come down to the scene because you're on call. Do you see that as a potential?
We had talked about having like an on-call, if I misspeak, just let me know. We had talked about having like an on-call side of it too, a team, even especially if we can't get a 24/7 coming up, that has been discussed. I don't know how much they actually have put anything into works for it, if you will, but that has been discussed too, because crisis doesn't have no time.
Right.
So, and we know that, and we are limited to our hours and not, from just, growing and expanding. It's a fluid program and it's gonna keep hopefully getting bigger and bigger so we can cover a 24/7 period because, I can't be in crisis now because they're not in. So, I mean, we understand that fully. So we're always open to, expand and to do whatever the needs of the community is.
My chief and I just talked about that yesterday. As to if they needed to call me in the middle of the night or something, that if it would be okay. And of course I said yes. Whether or not I'd be able to get a hold of one of my clinicians or not, if they're staffing at Mulberry Center, I could probably grab one of their
There is.
24-hour clinicians. If someone's over there, I could probably, I don't know how it would work out, but if in all in the correct world or whatever, if I were to get called in at 2 o'clock in the morning and there was enough staff at Mulberry to where I could just grab somebody over there and they could do a home risk assessment on somebody, that would be an option. So I know him and I just talked about that yesterday. I didn't know if they would be willing to do an on-call something or not.
And of course, let me tell you, we have, if there's a call going on and we've had hostage negotiations and stuff going on, that just because it's 4 o'clock and I'm supposed to punch out, doesn't mean I am. If I am already here and we have stayed overnight,
Yeah, we've done it a few times.
with the police and just to try to have, so they have us, because, you know, maybe we can talk them out because they don't want to talk to police. So if it starts in our hour and it ends 10 hours after we're supposed to be off, we don't, punch out and go home by any means. So we do have that expanded capability to stay in case of those situations. Thank you.
Same thing with the city, like, we don't have an official on call, but something big came out and they reached out to one of us.
I'm a crisis negotiator, so I am on call.
You're on the speed dial anyway.
Yeah, so if something big did happen, I would come in, and I think our department would probably be okay with Shelley coming in.
My question would be, how do you feel about, as we're talking multiple agencies, one thing that you have learned, there isn't any one agency that can handle all of this. So are you comfortable with the level of coordination and cooperation that you're getting right now between the various departments and agencies? Does that need to be kind of taken up a little bit?
As for police agencies, I think we're good. Like I do all of Wells Park. And then Tiffany and Shelley would basically take County McChesney. And then we split up the rest of the smaller agencies between the three of us. So like I have 110 people from Wells Park that I've just new this year that I've tried to deal with, plus another 50 or 60 from other agencies within the county. And they're basically right around the same. I would say each person has right now close to just new this year, 250 to 300 people on their caseload that they're like working with. So it's up there. The original thing for the unit was to decrease the calls for service from mentally ill, but you can't ever just decrease. You're still gonna get them, it's just how you handle it in the end is what it is. So it was originally set to decrease, but now it's not decreased, but now we're working on keeping the repeat callers from going to jail for miscellaneous little petty repeat crimes. And hopefully that works out because after January 1st, we're looking at, hey, they get arrested, they have to stay overnight anyways, before they see a judge and release the next day because there's no more cash bail. So hopefully we can keep them from going to jail to get them back on medication and keep them as productive members of society is the end goal.
From the mental health side, as a clinician, when we started, I feel that there was a lot of agencies that we had dealt with the same clients, but nobody was talking about it. They weren't communicating together to be like, oh yeah, I know John Smith, and I've done this for him, we've done this for him. So they started a community meeting of different agencies and providers that meet like once a month. And now we can talk openly about these clients. A lot of times people were hiding under the blanket of HIPAA, let's say, and because HIPAA that's what you're trained as a medical professional, mental health professional is HIPAA, privacy. But when it comes to like crisis and continuation of care, so if we're working with the same client, it's called client-centered consultation and continuation of care. We can talk about that client collectively without violating privacy or HIPAA violations. So I think that's come like a long way. Before it's, I can't confirm or deny, I don't have any information. And now it's kind of like, oh yeah, I work with John Smith too. What have you guys done? What can we do? How can we help? And so I think among a lot of the agencies, Stepping Stones, Jubilee, Swedes, Mercy, the Strive program, we're able to all kind of talk and say what's the best thing for this client and how we each have something maybe different to give. I've been doing it now, it'll be 2 years November, right? I still be like, what agency exists? I didn't know that was a resource. So I'm still learning on what's out there. So it's kind of nice. And we now are collaborating way more than I think we ever have.
Our team has, since we piloted the program, our networking has just expanded over the entire community. A lot of these, like Christy said, a lot of the things we didn't know about when we first started, and now with our networking and building these rapport with other agencies and services within the community, you know, we're a team of teams.
Yeah, that's what.
I just left the call with health department. So we're working with Winnebago County Health Department as well on homes that they're getting ready to condemn because the people inside are just not mentally right. So we're working on trying to get them into treatment, or if they do have to get out of the house, we work on getting them to housing and stuff like that.
The
So
community is well aware of our team. There has not been one time, not once in the 2 years that we've been doing this, have someone have said, we've been banned from the mission and we bring them over there and they're more than welcome to take them back. You know, kind of because I'm not trying to toot our own horn, but they'll be like, Christy, and I was like, why'd you kick my boy out? Why can't he come back here? And I'll get around and they'll just like, all right, we'll take him back. So if that person would have went to the mission on their own, they would have said, no, you're banned. But they have always took the band off and just said, okay, and then I just have to say, now behave, follow the rules, you know, I might have to give a couple of instructions. But not once when we brought someone there that was banned, have they said they would continue to be banned. They've taken every client.
So there's gonna be a different change in 911. Yeah, do you think that that's gonna have a positive effect on you're getting the right information right quicker than what you have been getting it?
talking about with 988.
Well, no, with 911 also though. And its connection with
That's how you talk.
yeah, with the Swedes program.
I haven't heard anything
Okay,
about that at all.
okay, all right. That's, okay,
You're in the future right now.
yeah, okay, no,
So the program is not done for one with the nurses at the
Yeah.
moment.
yeah,
Is that,
we went through that.
is that what it's gonna be?
We're-
Like,
We're paying for upgrade for 911.
Okay.
Yeah.
If they did a software, triage calls.
Yeah.
They're gonna be triaged over the phone through
Okay.
the nurse, and the nurse is gonna say where they should be.
Yeah.
Great.
Well, actually, a lot will be done even with the software.
Oh, really?
Yeah,
So they,
I do remember.
officers are getting the better information.
Do we know when that's going into effect?
it's gonna be over the next 6 months.
Okay.
After the first year.
Yeah.
Yeah.
And when we were there, that's what we wanted to do. Like, well, then there was the software coming in and the training,
Right.
maybe spring, I mean, it was gonna be a few months.
So it's way to help screen calls.
Yeah.
As opposed to
Really
just
categorize them.
paper up there.
Yeah.
Oh, wait,
Yeah.
That was education this year.
Okay.
All right.
I just want to say, since I've been a team lead since August, and in August, I started a spreadsheet to track our live calls, follow-ups, admissions to crisis triage and Form 5s and repeats. Every month since August, our repeat calls have gone down by 10 people. We started at 59 people, and every month we dropped down 10 people. So I think that we're getting the people the help they need.
Good to hear.
Thank you so much.
Thank you all.
Thank you.
Thank you. Thank you.
They said they called it for 90 days.
Yeah.
Yes. But what I think important is if there's a call in, we should start.
Yeah, right.
That's, thank you for the variety of grant services, you know, so that there's somebody.
Okay, we'll
Yeah.
push forward here. I just, for the record today, for the minutes, Kim has arrived, so we can. 2:20. We appreciate that crisis co-response team coming in. Very informative. So, moving on, monthly activity report. Jason, if there are highlights for that?
Yeah, I would like to highlight three really important things that we've been doing that align with in one case, our communication strategies, and in another case, our systems coordination strategies. So first of all, we were able to convene our first communications work group meeting in October. We had a number of agencies that have dedicated communications and marketing departments who participated in that. They were all very much engaged in the vision for that, to promote mental health awareness, throughout the community, but specifically through the lens of what's being funded by the mental health board. And so we think that's gonna really help take off. While the first couple of years, we've been really focused on building programs and building the capacity of organizations. We understand, it's been just board discussion multiple times about the importance of communicating that broadly so that everyone knows about it. And that is the mission that these agencies have been tasked with and that they are bought into. And the goal is to present to the mental health board in January from this group a project charter that outlines their kind of foundational objectives and goals, a timeline for specific objectives over the course of maybe a 12 to 24 month period. And then if there would be the need for any budgetary items, that would be included in that kind of overall picture. Not suggesting that there will be, but as we discussed, there may be the need for those. So we bring that to the board in January. So I want to give you an update on that. Linda has participated as a board champion for that, given her experience working for 2 funders in the past and having been able to kind of have that experience of co-branding and understanding what that looks like from a funder's perspective. I have also, Chelsea's not here today, otherwise I'd like to highlight her effort in making that happen and really commit to it. Something that Nicole and I have been working on together is partnering with the workforce board to establish a mental health career pathways committee, and they have done that. They have established a committee. There will be in January, we'll host our first meeting around that and start identifying the quick win type strategies, the immediate things that can be implemented, and the long-term strategies that are going to be needed. There are already commitments from a number of high schools and colleges, and the early things that I've heard back is that everyone that is approached about this is incredibly excited about it because they see the need for it. And so there has not been any hesitation whatsoever. While we appreciate all of the board energy around marketing and communications and appreciate all the champions we have for that, I really could use a board champion on the pathways. And so I'm not asking necessarily for a commitment in this moment, but if somebody felt that were an area that they'd like to plug into and attend those committee meetings and express the importance of this to some of these agencies participating from the board's perspective, certainly that would be welcomed. We could have up to 2 really that could attend meetings before we get into Open Meetings Act violations. So, up to 2 champions can be part of this. And then we also have been working with the Youth Mental Health System of Care Collaborative since they presented to us on their referral system, IRIS. And that has been completely signed off on by Rosecrans legal department and technology people as something that is implementable, that is consistent with HIPAA and everything else. And that they're going to roll that out. And they have asked, that committee has asked for a neutral party, I think I mentioned this the last board meeting, to be the data administrator to evaluate. This is going to give us a community-wide data set that's going to show the gap time between referrals to actual appointment. That's a critical part of our environmental scan, right? That we want to monitor over time. So there is no financial commitment to that. It is simply being a collector and aggregator of the data. So we have been asked to do that, and I have sat in those conversations, and I believe it would be appropriate for us to do that. One of the challenges that group is facing is getting other agencies to buy into it. And so I believe that we could host a a meeting with the IRS training crew to invite our funded organizations to come in and hear more about it. And that we could play a role in encouraging that utilization. Again, in alignment with the mental health board's vision for this coordinated system of care. So I have offered that we might do that, and that I think that that's something that will take place likely in December. And I would appreciate, once again, if you're looking for a place to plug in that maybe has something immediately to be involved with and champion, a board champion for that particular issue, would be appreciated. And so that's kind of the critical things that, you know, in addition to just managing the day-to-day operations of 30 grant programs and 30 financial requests and receipts and invoices each month, and getting ready for a new notice of funding opportunity in December. Those are kind of the new areas of growth that we're trying to move forward as it relates to our systems coordination efforts this year.
I also, I think that's, we're gonna have those kind of opportunities, but I think, it's important for the board to realize too, we're talking about the activity report. We did win, an award for grant. And what I felt was most meaningful about that whole presentation and just the whole day, Ramp did a great job of having, say, at their annual luncheon. They talked about all the services that they have begun as a result of the funding from the mental health board. And I mean, they spent quite a while elaborating on details of the programming, and I thought it spoke very well of, how the funds are being used and how the community is being impacted. And their speaker happened to come from, I still call it Sunstrand, but it's Collins Aerospace. She did a great job speaking, but there were a complete table of Sunstrand people, and I thought this is really great because I don't know how much they're clued into the mental health world and what goes on here in the community and the funding that is happening, and they obviously support RAMP. So it was really, I think, Terry was present, Jason was, Chelsea was, Nicole was, so it was a great luncheon. And then one final thing that I also wanted to mention is the NAMI rally. Jason had the opportunity to speak and did a terrific job. But again, all the speakers that came up, so many of the programs that they highlighted and talked about were programs that the mental health board funds. So just, I think it's important for, board members to realize that we are making an impact more than you realize. When you go to those community meetings and they're packed, and then you hear again and again about, we wouldn't be doing this without the funding from the mental health board. I feel like it's headed in the positive direction.
Very into that point, my question about the CCRT was kind of a trial balloon. Jason and I had a bit of an exchange. I really feel strongly, just for us and because our meeting is public, that when any group comes to present, my personal opinion, I'd like them to start with, we are receiving this much money from the Winnebago County Community Mental Health Board. With that money, we are able to do this, without which we wouldn't be able to do this. Because, here we have 100% funding, but we'll have others present who won't. We'll just be supplying portions of their program, portions of FTE growth. And I think it's just good for all of us to reframe the public who may be watching.
That's correct.
Who's doing it, but I think your point is well taken. He and I have had a little discussion about the why, because my wife and I are part of a group that's helping the capital campaign. And the Lutheran Church of the Good Shepherd now has an embedded Rosecrans mental health worker helping kids and families. And in the tour, the vision tour to raise money, Brent Fettenberg is mentioning that, has expressed willingness to be more public with that. So I think you're absolutely right. But when we see an example like that, we need to encourage that be mentioned widely and to broad audience.
I agree, and I think, you know, we probably don't know half what, you know, is being mentioned in the community, because luncheons go on about every other day for agencies, so, I think it is very important, and that's why I wanted to bring it up today, so.
Well, can I add, I was an alignment Rockford, that where Jason was one of the chief presenters of information about how the school district is doing with, I guess they've done a second data collection. The first one having been done by the Erickson Institute, I don't remember the.
UCLA.
Yeah, UCLA group that are looking at how our kids are doing in a pretty global sense by census tract. You know, so educationally, emotionally, blah, blah, blah. And I see that data as being tremendously important to us, as we're starting to think about what our next few funding priorities are going to be. And I'm happy to see Jason and Nicole involved in that. Because regardless of what the school district does, that data is sort of visible. They put it in visible form, so you can go, oh, interesting. What, you know, what more information do we need? And I'm sure that some of what is going on at the Lutheran Church across from West has to have been fueled in part by the EDI, where they're looking at a gap in a community resource, you know, absence of resources. And it's like, wait a second, we can fill that gap. And I love the collaboration, that it's not just us, that it's the Y, and it's a religious organization, and it's Rosecrans. And if all we succeed in doing is getting everyone sitting down together going, oh, I can do that. Can you do this? It will have been a tremendous success. So today was an example of that, you know, so.
Well, kudos on the communication group. I think that's such a wonderful idea.
I
And
agree.
even though you're talking about communication, they're sitting there with each other
Yes,
and they're talking, and I hope there's been no pushback in that group, because all these groups have mailers, they have board members, they, you know, all sorts of people and constituents and stakeholders who can be out in the community talking as long as they know. I think it's a wonderful piece.
Unequivocally, everyone that's been part of it has understood the importance of it.
Great.
Without hesitation.
Jason?
Yeah.
Just another question before I lose it, related to the system issues with the group here today. LP Johnson, this was not mentioned at all. Is that being used in the way that we had wanted it? Where there's people coming out of jail and yeah, exactly.
Yeah.
What, I mean,
So over the renewal of those programs, the jail and the College of Medicine. So there's two components, because the College of Medicine is the local provider of services, but as part of my understanding, I guess I should say, is that part of the university system, they have an FQHC, which is miles square, right? So what I believe is that the actual staff that are in the jail are employees of the College of Medicine, and then the practice that's outside of the jail is the FQHC miles square, and that there is someone in the jail who is coordinating with the jail's behavioral health program to do discharge planning. And then when it is appropriate, when an individual does not already have another provider that maybe they were seeing before they came in, you know, if it's a Rosecrans client, they're in jail for 15 days, they maybe go reconnect with Rosecrans. If they don't already have a provider, then they're made a referral, or at least given the option to go to Miles Square, and there is that warm handoff when that happens. And so I do believe that is happening, and that there's been a more formalized MOU after year one, I guess, just figuring out between both entities bringing in new staff, new programming, how do we work together? And I believe now in year 2, there is a very clear vision of how that goes and what the flow of people are between those two entities.
Miles square.
Yeah,
Yeah, and FQHC
Yeah.
is what Crusader is,
right,
Oh.
that's,
so they have their own FQHC.
They're headquartered out of Chicago, part of the University of
Right.
Illinois, Chicago medical system.
Yeah.
And are they at Elton Johnson? or-
yeah,
Yeah, okay, now thanks.
UIC,
yeah,
UIC.
But this-
UIC.
Johnson.
Yes.
Yeah, the school in place.
okay, any other slides or anything?
No.
Okay. Moving to our action items, I need a motion for approval of our October 2022 meeting minutes.
So move, second.
There we go, we have 10 minutes.
Let's move this along. huh?
Yeah.
Any discussion? Hearing none, all those in favor, please say aye. Opposed, same sign. Okay, the authorization to renew director and officers insurance and Jason.
I'm gonna try to make this as simple as possible. It's not as complicated as it might sound, but it is, there's options for you, okay? I'm gonna play my best version of an insurance broker here. So the board has carried, since I started working with you and we did the first round of procurement for insurance, was done by the board directly, not through Region 1's procurement, carried directors and officers insurance and professional liability insurance.
Right,
My best understanding of the difference between those two things, based on what the insurance brokers advise me, directors and officers gives you coverage on the functions of being a director and officer. Things like when Wendy, as the treasurer, signs a piece of paper that a treasurer signs to authorize a payment, that is a function of the role of a treasurer. The function of the role of the board president to host a meeting and do the things of meeting minutes. Now, if there are violations or errors that are related to those duties and functions, the directors and officers insurance provides you coverage for that.
Yeah.
However, there are things that the board oversees that are not specific functions of being a director and officer, such as grant making, for example. Where does the liability of grant making fall? We as staff have our own professional liability insurance, but the board itself has things that may fall with under your purview of decision making or advisement in some cases that may require that type of coverage of professional liability. Also keep in mind, when you first procured insurance, we did not have a intergovernmental agreement with Region 1 Planning Council. You had a 1-year service contract, temporary in nature. And so it's very important at that point in time for the board to have that coverage, and it may still be moving forward. We estimated insurance increases this year based on percentages of increase. Last year, we budgeted $19,678.75. Because of the increases in the board's budget and general inflation, the amount of insurance dollars has gone up significantly in the quotes we received. And it would put the board over budget if you renewed directors and officers and professional liability. It would be $23,853 total, putting you over budget on that line item, $4,174.25. So there's two things here. Number one is that's why I formalized the authorization, right? Because it will put you over budgets to authorize those expenses. We can, the insurance broker has offered to reshop these policies. It's been 2 years since they shopped it. The first time they shopped it, everyone declined except for one insurance carrier. And just because of the large size of the fund. So they can reshop it, doesn't mean we're gonna get more quotes, but they have offered to reshop it and see if there's a lower cost. In the meantime, you do not want coverage to lapse, I would imagine. So, so two options for today. One thing is that we will reshop it and I'll bring back those prices and options to the board. Okay. Secondly, for today is the option of authorizing these in full. And then if you do change policies, you cancel a policy, you get reimbursed for the months that you have not used. The other option is to finance, so you're not committing to a, necessarily, you're not making an authorization today that puts you over budget, you're just buying time by financing it and saying, you know, we're gonna not pay it all up front, but then you might see a finance charge associated with that. They're not gonna finance it likely for no interest, so. So the first action item today is for the authorization to renew directors and officers insurance. And I would ask that in the consideration of that, that you maybe specify also if you're authorizing to pay that in full, so I can process the invoice.
Do you know what the finance charge would be?
I don't know. I just got the indication right before the board meeting that they were willing to finance it, but they didn't provide me a finance percentage. Yes.
So earlier you were talking about, we're not covered for some board duties that we do, like the, grant making. So is there any insurance or is there anything that we can get covered for?
Outside, that would.
I mean, was,
That's what.
Well, professional liability would cover it.
It does cover.
It does cover it, yeah, it's just the combination of both things together. Both of them went up because of the increased fund, and the combination of them together.
So, did you get an opinion from the insurance company about dropping, no, the lawyer can't advise, we know that, she said. We had to go back to the insurance.
So, okay, I asked, one of the potential things here was, we asked the legal counsel if, but by virtue of now having an intergovernmental agreement with Region 1 Planning Council, that maybe the board didn't need professional liability anymore because perhaps the staff themselves were the ones providing the professional services and were covered by R1's professional liability insurance. So the advice on that was if we were going to go down that avenue, that the IGA be amended to indemnify the mental health board explicitly from that, so that it's clear that the liability is solely falling under Region 1's policy, which could create increased cost for Region 1. So I'd have to explore that option. So really that whole thing becomes part of we have to shop it, and we can shop that option along with the board getting its own policy through a different carrier.
Just a couple of questions, Jason. So your original description, if I could word it a different way. So the D&O insurance, let's say, for instance, to put an example to it, covers certain activities, but the professional liability would cover annually our voting to approve the grants to the funded programs. You kind of separated that maybe as a different function that D&O doesn't cover?
I would say it covers professional services that might be provided by the board or under the board's purview. It is not, you'll never get an insurance agent to give you a specific yes, this, because it's basically risk, right? It's your risk tolerance, and anybody can sue for any reason they come up with, so they can't give you an explicit, but the difference would be a board officer function versus a professional service function.
So in that description, so services that come under the purview of the board, I think you said, that would be you all. So is that liability covering us for your actions, for us as board members, since you are the professional services?
That's kind of what I am wanting to get more clarity on,
Okay.
that I don't have 100% clarity on at this moment.
Well, so, but, all right, so angry client getting services at X organization decides they're gonna sue X organization. And in discovery, they discover that the funder of the program that they are participating in at X organization is funded by the Winnebago County Mental Health Board. There is a fair chance that the lawyer would just sue everybody, including us in our board capacity.
Deep pockets.
Right, so whether or not we get dismissed out or not, we now, either as a board or as individuals, may have an obligation or would have an obligation to show up in court with legal counsel. And the question is, who's gonna cover that cost?
My question is, okay, so in that scenario, where's the liability? And is it covered under DNO? Or in that example, is do we need the liability?
That's what I would say, the liability, that's my
Okay,
guess. Don't take it to the bank, but that would be my guess, that it would be covered under liability.
Just even a better, simpler example is what happened to me the other day.
Oh, I got a text message from somebody looking for help with a placement for a family member. And well, thank goodness, before I responded, I tried to call Jason, and I ended up calling Mary Ann. I said, what do you think how should I respond? And we talked about it, and then my response was, you know, I'm a officer or I'm a member of the board, we don't provide services, but here are some resources, you know, and then it turned out that the person involved was a minor. And I said, well, you know, my experience is SAS, you know, is a reasonably good local resource. And the person said, are you telling me I should just follow what SAS said? And I texted back, I said, I'm not telling you anything. I am giving you information to help you on your search.
But that's just,
But I could have gotten into deep
what
water
if
there.
something happened to a child? Then
You know, have I, you know, put my foot in it, I don't.
So there's that, yeah, there are functions that would clearly be ones that the board members could say, well, we just need to be cautious that we don't do that because we don't have professional liability. One of the things the board members do that would maybe be questionable where it falls is, while voting to approve something would likely be the function of an officer, is scoring applications the function of an officer?
right.
Or is that a professional service, essentially?
It sounds like it's gonna be murky, even for
And-
the insurer.
From the insurer, there's never, in my experience, a 100% clear answer because they're in the risk management business, and so they're covering their own liability, not giving you the definitive answer, right?
This kind of isn't to be flippant about $4,000 budget variance. right?
It's $4,000.
I'm not meaning to be flippant about it, and I don't know if our philosophy or practice would be to budget neutralize that, so for taking it from somewhere else. But if it's that murky, I would hope we would move toward protecting us to whatever maximum degree we should be protected.
Let's just cover it, let's.
I would want to make a motion.
yeah, well, we'll authorize the renewal for the
You
director
authorize
in
renewal
office.
and we pay in full.
Well, that's what
Okay,
I'm doing.
so we have the motion,
Section.
you'll second. Any further, just no further discussion.
Do we have to do a budget amendment for the county or?
I'm quite sure it'd have to be a budget amendment, but not necessarily to a county, I don't think, just a budget. No, it don't have to be a budget amendment, because we just offset, yeah.
Well, are we pregnant? That's the other.
I think that, yeah, what we had previously discussed for line items that were over last year, as long as the full budget wasn't over. that-
Yeah.
So I think we could kick the can down the road a little bit and see it. So in a moment in the future, if we need to do a budget amendment, because we are in fact going to be over budget, but I don't think that would be the case.
Right,
Okay, so we have the motion, we have a second.
right.
No further discussion.
So
Hearing none, all those in favor, please
it's
say
money,
aye.
it's money, it's money, it's money.
Oh, it's money, yeah. We have to do the roll call. We have to do the roll call.
Yes, I would just say, let's just do the roll call.
This all.
Mary Ann.
It's money, sure.
Ed Copeland not here, Dr. Jerky,
Yes.
Dr. Gorski.
Yes.
Dick Hooter,
Yes.
Wendy Larson Bennett.
Yes.
Tim Neighbors.
Yes.
Linda Sanquin's not here, Jason Holcomb doesn't vote in. Okay. All righty, so, that motion passed, and now we need another motion for authorization to renew the professional liability insurance.
Also move.
Okay, Wendy
Second.
and Tim, okay? So we have a motion and a second, any discussion? Hearing none, all those in favor, please say aye. Aye, opposed, same sign. So we have the authorization for you to go ahead and renew professional liability in full.
All right, I will do that.
All right,
Thank
I will let you know if the agent, they will still shop it, and if we find, for due diligence, if we find something, a cheaper option with the same type of coverage,
Yeah.
I'll bring that back.
very good. Thank you.
Thank you.
I have no discussion items. And nothing under other matters.
I move for adjournment.
Okay, all those in favor?
Uh,